updated and carefully reviewed expert guidance and information related to the management of patients with COVID, with special emphasis on the need for oxygen and how to deliver that, but also more broadly, really all aspects of care. So looking forward to the webinar today. Dr. Lipnick, back over to you.
Thanks very much, Dr. Cyberry, and we will go ahead and jump into it. We have quite a full program today. We're going to be talking about COVID-19 diagnostics. This clinical updates webinar is hosted by USAID's STAR program with support from USAID, as well as collaboration with UCSF as part of the Oxygen Ecosystem Initiative. We're going to talk over the next hour about COVID diagnostics. We'll include an update on the overview of different diagnostic testing, key considerations for implementation, as well as some lessons learned in 2020. We'll also be sharing some resources that are on the portals that have been created with support from USAID. And that will follow the talks. After the talks, we'll also have some time for Q&A. So please, we encourage everybody to share questions in the Q&A chat at the bottom. We will be recording this session. And just as a reminder, what is shared here is not considered medical advice. This is really intended to be educational and informational. It's also intended to be interactive. So we look forward to participation in the Q&A. The broadcast will be live in English, Spanish, and French. So at the bottom of your screen, you can select your preferred language. And again, just as a reminder, the Q&A button can also be found at the bottom of your screen. Lastly, this series takes place on the second or fourth Tuesdays of the month. We are open and would love to hear from participants about topics that we can highlight to make this time together as useful as possible. So please contact either myself or Lauren, or enter into the chat window today topics that you'd like for us to include. Relative to diagnostics, there are a couple of resources that we will go through at the end. Just briefly to highlight, there is a COVID-19 section on the Open Critical Care portal, as well as a suggested trainings page. I also want to highlight the COVID protocols.org website, which includes a section on COVID testing in both English and Spanish that was done in collaboration with Partners in Health and Brigham and Women's Hospital, as well as some of the material from Partners in Health, which we'll highlight later in the session. Joining us today as speakers and on the panel, we have Dr. Chaz Langlier from UCSF. Chaz is an assistant professor of medicine. He is at the University of California, San Francisco, and also the Chan Zuckerberg BioHub. He's Associate Medical Director of Hospital Epidemiology and Infection Prevention Control, and also has been an NIH-funded researcher bridging basic science and clinical medicine. His area of interest is broad and is a leading expert in diagnostics, specifically around respiratory care, and he'll share some of his work with us here today as relates to COVID-19. We're also joined by Dr. Nidia Correa. Nidia is a microbiologist, currently serves as the Associate Lab Director at Partners in Health. Nidia has been providing technical assistance to Partners in Health labs in multiple countries around the world. She has a huge amount of expertise in the area of COVID diagnostics implementation, and that she'll be sharing with us today. We're also joined by, on the panel for Q&A, we'll be joined by Colleen Ben, who is the longstanding Director of Laboratory Services at Chinle Health Services Center and the Indian Health Services Center in Navajo Nation. Very fortunate to have all these panelists. And without further ado, we'll go ahead and hand over to Dr. Langlier for his presentation.
Great, thank you so much, Mike. Let me just go ahead and share my screen. All right, well, hello everyone, and thanks for the opportunity to have a discussion about COVID diagnostic testing. And so I'd like to just start with some lessons learned from 2020 to kick things off on this topic. And I'd say number one, we've learned that testing is really an essential cornerstone for preventing SARS coronavirus transmission. Number two, that many infectious people are asymptomatic or pre-symptomatic, meaning that testing and surveillance is really important. Number three, that false negative tests are common, but they vary depending on the type of test used, the timing of the testing with respect to symptom onset, and the type of specimen. Was it from the nasopharynx or the oropharynx, et cetera? Testing more frequently with less sensitive rapid tests can be almost as effective as infrequent testing with highly sensitive tests. And number five, that most patients shed virus for weeks to months, but are rarely infectious beyond 10 to 20 days. So there's not a need to retest most patients after an initial diagnosis, a key point in terms of conserving testing resources. And I just want to highlight some key points before we delve into things. I'll emphasize these again at the end. But number one, as I mentioned, many infectious people are asymptomatic or pre-symptomatic. Who are the key people to test? People being admitted to a hospital, living in congregate settings, or working closely with others. Who not to test? People who've had COVID within 90 days because they're likely to return positive on a test and may no longer be infectious. What tests do we use to diagnose acute COVID? PCR or nucleic acid amplification, the most sensitive tests, which has certain use settings, as well as antigen tests, which are less sensitive, but inexpensive and fast. And the key point to emphasize again, testing more frequently with less sensitive rapid tests can be almost as effective as infrequent testing with highly sensitive assays like PCR assays. And the last key point, that antibody tests really are not useful for diagnosing acute COVID. They have great purpose in terms of epidemiologic surveillance, but not for diagnosing acute disease. Okay, with those key points in mind, let's talk some details. So what are the different types of COVID diagnostic tests? Well, number one, we have nucleic acid amplification tests. Polymerase chain reaction, PCR, is the most common. This is a test that detects viral RNA. You're seeing a picture of the Cepheid Expert instrument, which is a prototypical PCR instrument. And PCR works by detecting regions of the viral RNA genome. You can see the 30,000 nucleotides of the genome diagrammed here. And different regions of the genome are targeted with these PCR assays. Okay, test type number two, antigen tests. So antigen tests detect viral proteins as opposed to viral RNA, like the nucleocapsid protein, for instance, or the spike protein. An example of antigen tests are the Abbott Binax Now card, kind of looks like a home pregnancy test, laminar flow assay. You put a swab sample on a card, you get a line if someone is positive versus negative. Then we have antibody tests. So antibody tests detect human antibodies against the viral proteins. There's a human antibody binding spike protein, and then you have some type of molecular readout, a color change or whatever, that allows you to know whether or not human antibodies are present. So one way to think about diagnostic tests is to think about their limit of detection. How low can you go? How little virus can you detect with a diagnostic test? And this is often measured in genome copies per milliliter, and this is relevant to nucleic acid and antigen tests. So the most sensitive at the left side of the screen here are the reverse transcriptase PCR tests. This is really our gold standard for testing. Turnaround time typically is 45 minutes to a couple of hours. Delays may be longer depending on infrastructure in a laboratory. Kind of in the middle, we have rapid nucleic acid tests. A common one that falls into this category is the Abbott ID Now test. It uses a loop-mediated amplification, gives a fluorescent readout, does it in 15 minutes, but it's not as sensitive. It takes 100-fold more virus to turn this test positive. And then kind of towards the lowest sensitivity side of the spectrum, we have antigen tests, which are very fast, very cheap, and as I'll tell you in a little bit, have an important use scenario in many cases, especially in resource-limited settings. Just a comment on antibody tests. So I mentioned that they're not useful for diagnosing acute COVID. Why is that? Well, it's simply because it takes time for humans to produce antibodies to pathogens that are infecting them. You're looking at a curve here of the positivity rate on the y-axis of an antibody test versus days from symptom onset. And you can appreciate that, you know, after 7 days, less than half of people, or approximately half of people, are going to have a positive IgG, for instance. If you get out to 14 days, then we're talking around 80% or more, you know, and if we're at 23 or more days, then most people who are immunocompetent are going to be producing antibodies. So not useful for diagnosing acute disease, but highly useful for understanding if someone has had COVID. Just want to make a comment as you think about potential use cases of antibody tests. I want to make the point that performance is variable. This was a study done over the summer at UCSF and other institutions looking at the time, most of the available commercial antibody tests. And 2 take-home points from this slide. Number 1, that sensitivity is very low early on, as I just mentioned, but that there's, you know, notable variability between the companies producing these tests. And there are quite a few out there. And so it's important to understand the performance characteristics of the specific antibody test you might be using. This is a website that is maintained by the US FDA that has performance metrics of all of the FDA approved, FDA EUA antibody tests. So that's a nice resource to compare how well they perform sensitivity and specificity. Okay, but let's talk a little bit more about RT-PCR tests, because essentially, for the majority of the pandemic, this is the central type of testing platform that has been used. As we talk about PCR tests, I need to mention something called the cycle threshold, or CT value. So polymerase chain reaction involves cyclic amplification of nucleic acid. So in the case of coronavirus, we take the viral RNA that's extracted from a sample, nasopharyngeal swab sample, sputum sample, etc. We turn that into DNA, and then we amplify it with a number of cycles called a polymerase chain reaction using a polymerase. And depending on the amount of RNA present in the sample, you get a different number of cycles required to get a signal. The more RNA and material in the sample, the fewer number of cycles it takes to get a fluorescent signal. If you have very little RNA in your sample, then it takes a lot of cycles in order to detect anything. So a lower CT value means more virus in the sample. I'm bringing this up because many people talk about CT values. In fact, many of you on the call may be very familiar with CT values, but it's an important thing to discuss, and I'll be mentioning CT values throughout the talk. If we take a look on the right, you can appreciate the inverse correlation between CT value and viral load. So the amount of virus is on the x-axis, increasing from left to right, and the CT value decreases on the y-axis. So the lower the CT value, the more virus in the sample. And the different color lines here represent different hospitals with PCR assays detecting different parts of the virus. And you can see that by and large, they are quite similar with respect to most of the targets. The one exception is the one in pink down here at the bottom. This is the RNA-dependent RNA polymerase gene in the coronavirus genome. For whatever reason, it is not expressed at very high levels, and so the CT values in general are higher for that target. So it's not a common target of PCR assays. Okay. One of the key points I wanted to make is that the sensitivity of coronavirus PCR tests, our gold standard, vary rather significantly based on sample collection site. This is kind of a compilation of data from a few studies, mostly earlier studies, but essentially the take-home message is that your lower respiratory sample, a bronchial lavage, endotracheal aspirate, is going to be the most sensitive, the most likely to detect virus in someone who's infected. Then you have sputum. Then you have a combined nasal pharyngeal and oral pharyngeal swab. You can see the performance of a nasal pharyngeal swab alone, and then an oral pharyngeal swab is probably the least sensitive. Now there's variability here, and A key thing that determines variability is the timing of testing with respect to symptom onset. But before we go into that, I just want to make a comment about who collects the tests and does it matter? So this was a debate, I think, early on in the pandemic. Is self-testing acceptable as an alternative for testing by a healthcare worker? So what you're looking at in these three panels are a comparison against healthcare worker nasal pharyngeal swab testing on the y-axis and the testing results from a patient-collected swab. So on the left, we have a tongue swab. In the middle, we have a nasal swab. On the right, we have a mid-turbinate swab, so farther up the nose, but not quite the nasopharynx. And basically, the take-home message is that you don't need to be a healthcare worker in order to obtain an effective swab sample. Patients can do their own swabbing, and that mid-turbinate or nasal swabs tend to perform better and are more accurate with respect to healthcare worker performed nasal pharyngeal swabs. And not surprisingly, as I mentioned on the last slide, an oral tongue swab is not quite as good. But patients can do their own testing, and it's essentially as good as healthcare workers, which is not surprising. I mean, we're not talking about rocket science here. It's sticking a Q-tip up someone's nose to get a sample. Okay, I want to bring up the concept of negative predictive value, something that probably many of you have thought about, but it has relevance for diagnostic testing. And it is the probability that a negative test means the patient doesn't have COVID. And it's a useful metric to keep in mind because it varies with the prevalence of disease in a population, and it helps inform when we might need a more or less sensitive test. So if we're talking about COVID prevalence of 1%, which is the case in some countries, then really it doesn't matter that much what the sensitivity of the test is. The negative predictive value is going to be very high. For all intents and purposes, if a test is negative, when you have very little virus circulating in the population you're testing, the chance a negative test means the person is truly negative is really high. And you can appreciate that this decreases, the negative predictive value decreases if the prevalence of disease is higher. So if you have more coronavirus circulating in a population and you have a less sensitive test, then you can't trust as much a negative result. So I want to make that point. Okay. So a key question that's out there is, do we really need a highly sensitive test? We just spent a couple minutes talking about PCR assays, PCR instruments, while way more widely available than they were 10 years ago, are still expensive instruments. They usually require a central laboratory. They're not widely available in small clinics in rural areas, et cetera. So are they necessary? Well, to answer that question, we should think about the dynamics of coronavirus viral load and infectiousness. And these are data that essentially are modeling infectiousness as a function of days from symptom onset. And they come from a study of transmission pairs. So a study, in this case, of 77 people who were known to have transmitted coronavirus from one person to another. And these people were followed longitudinally, and from a significant amount of mathematical modeling, the relative infectiousness as a function of days from symptom onset was measured. So the density here refers to density of infectiousness. And kind of a key take-home message from this paper is that 44% of infectiousness and transmissions happened before symptom onset, which is pretty significant and explains in part why we're in a global pandemic. It's because people transmit coronavirus without knowing they're symptomatic, which also emphasizes why testing is so important. But you can also appreciate that infectiousness, which correlates with viral load, significantly drops off after about 7 days. So do we really need to test people who are many days out? These are data that evaluated 129 patients with respect to the amount of virus in their respiratory tract and culture positivity, which is a surrogate for infectiousness, as a function of days from symptom onset. And the results here really highlight that people stay PCR positive for a very long time, 40 days, 30 days, virus is still detectable. That's the orange dots. But that pretty much after 20 days, no live virus is able to be recovered from these patients. So people, by and large, are no longer infectious after 20 days. And the reason for that is because people make neutralizing antibodies, amongst other things. Low amounts of viral replication can happen within a person, but live infectious virus is not readily produced from an individual, even though viral RNA may be shed and detected. So this study went on to take all of those dots on the plot on the last slide and model it. And the model more clearly emphasizes what I was just mentioning. So here on the left panel, we're looking at duration of symptoms on the x-axis, probability of positive culture and infectious virus on the y-axis. You can see that after about 10 days, there's a very low probability, even though the tests are PCR tests are positive, that someone is infected. On the right panel, we're seeing probability of infectiousness positive culture as a function of viral load. And this makes an important point that the more virus a person has, the more likely they are to be infectious. And that's another key point to keep in mind, especially as we ask ourselves, do we really need a diagnostic test that can detect extremely low viral loads? Does it matter if someone's not infectious? Why do we need to detect the virus? Okay. So this is a figure that is very akin to the last one, but it shows the fraction of culture positive samples from a study in England as a function of viral load measured by CT value. So if you remember, low CT value equals higher viral load, high CT value, low viral load. And you can see that a majority of samples are culture positive, equating to infectiousness at high viral load, and then this drops off pretty significantly at CT values that are higher. And above a CT value of 35, extremely low probability that that represents an active infection. So how does this translate into what type of diagnostic test is most appropriate and most useful for a given setting? Well, we can take a look at this plot here. And this is a plot essentially showing the viral load dynamics, very similar to the modeling study that I had shown on the previous slide. So viral load here is represented by a number of dots. And then we see two limit of detection lines. We see a gray line, which is a higher limit of detection for a less sensitive test, like one of these antigen tests. And then we see a pink line for a very sensitive PCR assay with a lower limit of detection. And the pink dot is a hypothetical sample that is obtained, a test that turns positive. And we can see for this pink dot, in this case, the person has a high viral load, they're actively infectious. It doesn't matter what kind of test you use, you're going to pick up the infectious person. So in this setting, at this point in time in the person's infection, doesn't matter if we have a fast, cheap, less sensitive antigen test. If we take a look at the areas in yellow here that are actually missed by the less sensitive antigen test, we see two areas. We see the area on the right, which is someone who still is PCR positive but is no longer infectious. This is the area that we really don't care about testing someone. We don't really need to know if they're COVID positive in terms of their RNA because they're no longer infectious. The one area where it is critical and that we do miss out with the less sensitive test is this area on the left. So early during infection, when the viral load is climbing, but it's not quite high enough to be detected by the low sensitivity test. A short window, but a critical window if you only get a single chance to detect someone who might have COVID, such as a single screen before someone gets admitted into the hospital, et cetera. However, if we test more frequently, which is why frequency is underlined, the chance that we actually pick someone up quickly is very good, even if we use a low sensitivity test. If you only get one shot at testing and you're using an antigen test and you happen to fall into this window before detectability early during disease course, then you completely miss out and you miss an infection. However, if you test them daily, you'll pick up that infection the next day. And so this paper tried to model the difference in terms of infectiousness removed due to testing with the two types of test platforms. And essentially what they concluded is that if testing is done daily, there is essentially no change in terms of the ability to identify and remove infectious people from a given population. You can see that if things are extended out to a single test once a week, that there's more of a difference between the low and high sensitivity tests. But the key take-home point is that more frequent testing with a less sensitive test can overcome, in most cases, limits of detection. The other correlate here is turnaround time for the given test. So we can take another hypothetical example. In this case, we're looking at panel A, the green dot, same point in time as on the last figure. If the test takes 2 days to turn around, let's say they have to send the sample to a central lab, they do a PCR test, but it takes 48 hours to get the result. It turns out that in this particular modeling study, that 48 hours at this point in a person's infection would equate to almost 1/3 of their potential infectiousness. So by having to wait 48 hours for your result, the chance that someone transmits until they get the result back is pretty significant. And this study went on to model the effect of a reduced diagnostic delay or a faster turnaround. And you can appreciate the results here from the more sensitive tests in red, pink, the less sensitive tests in gray. And you can see that the ability to reduce the R value significantly drops off if you have a greater diagnostic test delay. In many places, it's not uncommon for a week to go by before someone's test result comes back. In that case, a week delay really does not do a whole lot in terms of removing an infectious person from their results. So this really emphasizes the value of a rapid test. Okay, to comment just a little bit more on the antigen tests, I just want to focus on probably the best studied antigen test. It's this one called a Binax Now card. And this was a study that was done in San Francisco in the Mission District part of the city. And this was a population surveillance study. They compared Binax antigen testing to PCR in an effort to screen an underserved population. And basically the take-home message is that for situations with high levels of virus, the less sensitive, fast, cheap antigen test does just as well as PCR. We get as many, it's all blue dots below a CT value of 30. If we set the bar to 35, which, based on the limited data correlating culture to CT value essentially suggests above 35 chance of infectiousness is exceedingly low, then you can see one case was missed here by the antigen test, but by and large, the antigen test got most infectious, presumably infectious patients in this surveillance study. And then we see in cases where viral load is very low, then the antigen test misses almost all of those cases. But the argument is that we don't actually care that much about people with low amounts of virus unless they're in that small window at the early stages of infection. So to put this all together and to summarize, when do we need a sensitive test? When do we really need to capture people in that very small window where they may be infectious but are missed on a less sensitive cheap antigen test but would be picked up on a PCR test? Well, really this is in a situation where you only get one option, one shot at testing, and the person is in a very high risk setting, like a person being admitted to the hospital. If you test them and they are falsely negative, they go into the hospital and that may lead to an outbreak because everyone thinks that they don't have COVID, but they do, and they're not on isolation. Or other high-risk settings, such as someone being transferred into a nursing home or someone working in a community setting with a lot of interactions with other people. If there's false assurance that they're COVID negative, they may transmit to other people. But for doing surveillance studies for many use cases, and I should probably also add in resource limited settings, then an antigen test is going to be the way to go. It's a rapid turnaround time and it's much less expensive. One slide to comment on false positive tests, because this has been in the news for one, and it's something to keep in mind. So these are most often due to laboratory contamination, at least if we're talking about PCR assays, which are both sensitive and specific with respect to other tests. This is a scenario typically where a small amount of viral RNA somehow ends up throughout the lab or spills over from one sample to another, and you get a false positive result. This was actually a problem at the US CDC almost a year ago when they were first developing their PCR assay. They had viral nucleic acid contamination in one of their reagents, and this confounded a bunch of the early rollout efforts. False positive tests are going to be more frequent in the context of low prevalence screening testing. So if you have a population with an exceedingly low prevalence of SARS coronavirus, the chance that a positive test is not real is going to be higher. You have a low positive predictive value. And at one point at UCSF, for instance, over last summer when coronavirus incidence was very low, we had about 5–8% of positive results in asymptomatic screening populations that were false positive. I should also just mention that some antigen antibody platforms have low specificity. They may turn positive due to common cold coronaviruses, et cetera. Some antigen antibody platforms are highly specific, so there's quite a bit of variability. I briefly want to mention a diagnostic technique that is becoming increasingly available, one that I study for my research, and the diagnostic technique that allowed the world to first understand that we were about to embark in a coronavirus pandemic. So this is called metagenomic next generation sequencing. And the way it works is that it involves looking at the nucleic acid sequence of RNA or DNA from a biological sample. So for instance, if someone gets a nasal swab test, like one of the first patients with an idiopathic pneumonia syndrome in Wuhan, they actually had bronchial lavage that was used for metagenomic sequencing. RNA is extracted from that. It's turned into complementary DNA. The DNA is broken up into small fragments, and a series of biochemical reactions are performed that allow these sequences to be decoded and read on a sequencer like the one shown here on the right, an Illumina iSeq, which is now used in a number of countries, in part through Gates Foundation's efforts. And from these sequences, the genome of whatever microbes are in a given sample can be identified by aligning against the genomes of all known microbes on the planet that have been sequenced. And it was using this approach that we were able to identify SARS coronavirus as the culprit for this emerging idiopathic pneumonia syndrome a little over a year ago. Metagenomic sequencing and genomic sequencing has become more widely discussed of recent because of the emergence of several SARS coronavirus variants that have some different features in terms of their transmissibility and potential biology. And essentially, the way that these variants are identified is through genomic sequencing. So a swab test, another test is obtained, RNA is extracted, that is sequenced, and then we can actually reconstruct the genomes of the viruses and ask how similar or different they are from one another. This is a phylogenetic tree maintained on a public database called USAID that captures almost all of the coronavirus genomes across the world. We're looking at a tree just of coronavirus genomes within California sequenced at the Chan Zuckerberg Biohub Research Institute. And you can appreciate the variability in terms of their relatedness. The closer things are on a phylogenetic tree, the more similar that they are to one another. It was this type of genomic sequencing diagnostic testing that allowed us to appreciate the emergence of B117 in England over the past couple of months. You can see B117 here in lime green, and you can appreciate its emergence starting kind of at the end of August and then taking off. We now know that that is because of increased transmissibility of this particular variant. And as we're discussing variants and diagnostic testing, I should also mention that due to the nature of PCR assays, which require detecting certain regions of the viral genome, PCR assays that detect the spike protein gene, which in a number of these variants that have arisen has mutations. If the PCR target is in a region with a mutation, you may get a false negative test. This was evidenced by Public Health England's identification of false negative S gene targets on their PCR assays. And you can see how the number of so-called S dropout results increased as B117 emerged. Now, fortunately, most PCR assays have 2 targets on them. So even if the spike protein gene target is no longer viable, then usually the other target may return positive. So that is just something to keep in mind as you think about diagnostic tests. I think moving forward, there will probably be a move away from using spike protein gene as a PCR target or target for other nucleic acid amplification tests. Okay, so to wrap up, let's just go through the key points one more time. Many infectious people are asymptomatic or pre-symptomatic, which is why testing is so important for controlling disease, one of many reasons. Who to test? People in high-risk settings, people who are going to be admitted to a hospital where they may infect others, living in congregate settings, or working closely with others. Who not to test? People who are known to have had COVID, who have had confirmed COVID within 90 days. They're unlikely to get value from another test, and they're unlikely to be infectious beyond 10 or 20 days. The tests to use to diagnose people with acute COVID, PCR or nucleic acid amplification, the most sensitive, but antigen assays may also have an important use case. They're less sensitive, but they're inexpensive and fast, and if used more frequently, are essentially almost as good in most cases as a more sensitive test. And that antibody tests really aren't the test to use for diagnosing acute COVID-19. So with that, I will wrap up and stop sharing my screen.
Thanks very much, Dr. Linglayer. We're going to transition over to Dr. Correa, and if you have questions about the talk that you just saw, please enter them in the Q&A at the bottom, and we'll get to them in just a few moments. Dr. Correa, over to you.
Thank you. Thank you. So what I want to do today is just kind of build up on the presentation, great presentation from Dr. Chas, and just to share our experience from PIH regarding the logistics part and the operational part. So next. So just let's go back to the main goal of the lab is to provide a reliable, accurate, and timely test result important for clinical decision. So next, there are many, next, Michael. So there are many aspects on the clinical lab that we have to take into account in different phases, in the pre-analytical, analytical, and post-analytical, that all these factors affect the quality of this test result. And as Dr. Chas just presented right now, in PIH, we were able to implement both the rapid test and the molecular test in different countries, and I'm just gonna show you an example of that. So for this implementation, we had several challenges. We had the regulatory approvals of the new rapid test last year at the very beginning of the pandemic. WHO didn't allow the use of rapid antigen test, and it was just until September that they were open to allow the use of the rapid antigen test. We also saw some challenges in the lack of a lab infrastructure regarding the space, the equipment and reagents, and also the lack of a skilled lab personnel, and all this mainly for the implementation of the RT-PCR procedures, and also the lack of lab information systems for reporting results. So we faced all those challenges. Next. And we can say, for example, we have some successes. One that I want to point out is that we provided mentorship and technical assistance for all our PIH supported sites in Africa and Haiti and Peru also. And we created lab capacity for RT-PCR in rural Haiti. And we did this with in collaboration with the Ministry of Health, who help us with the training of the lab personnel. We also, at the very beginning, used the Gene Expert for SARS-CoV-2, and the use of those cartridges improved the turnaround time. So with this implementation, we were able to increase the laboratory capacity regarding the infrastructure equipment. And the main thing was the training of lab personnel on new technologies. With this RT-PCR already established in the lab, we could use this technology for future outbreaks and also for routine diagnosis of infectious diseases. Next. So is all these parts, I mean, it was already mentioned by Dr. Chaz, but this is just like a, just to kind of wrap up and to complement what he said. So when you are faced to roll out or to implement those tests, you have to think, okay, what is the reason for testing? Do we need that for diagnosis, for screening, or for surveillance? And other key elements that you have to take into account is that the tests that you use, they have to be accurate, and they have the turnaround time needs to be good for clinical, for the clinical decision. So for example, if we want to diagnose, as he already mentioned, we should choose the more sensitive, which is molecular test. But if you don't have a molecular test, you can use an antigen test. So for the screening, the one that is more used is the antigen testing. And for the surveillance, you can use antigen and antibody testing for surveillance purposes. Next. So other things that you have to take into consideration is the test capacity. So you need to think about the throughput of the test, the cost, and the availability of this test. So for example, the RT-PCR, they are high throughput, but they are not that rapid. And while rapid tests, they are rapid, but you cannot process too many at the same time. So for the turnaround time, pretty much what it is also, you need to have a rapid, a rapid result within 1 or 3 days. So you can be, for clinical decision. And also, as well explained by Dr. Chaz, the disease prevalence also you have to take into account when you are selecting the test, and what strategy are you gonna use. Next. So some general recommendations for antigen test. This is taken from WHO. So you can use it for outbreaks response, the outbreak investigation and contact tracing, monitor trends and disease incidents, like in a specific areas of the hospital or in schools, community transmission screening, and testing of asymptomatic contacts. Next. The other things that you have to take into account is the test. So there are 10 factors that affect the test that you choose. And so among these factors, we have the available data that you have from the manufacturer, especially like for the clinical tests that they perform. Really good performance. They have to be more than 80% sensitive and more than 90% specific. You have to take into account the regulatory status, FDA or CE approvals, the manufacturer capacity, the distribution and technical support that the manufacturer gives you, shipping and storage condition, shelf life, specimen collection requirements, the contents of the test kit, if you have everything in the box, or you have to buy more things to perform that test. Obviously the cost and how easy is to use. The next. I think it's the key messages that we want to give you with these presentations is pretty much that the RTTs are more feasible for many low and middle income countries, especially in those places where RT-PCR is not feasible or it takes a lot of time to get the result. You have to take into account local factors such as test capacity, the turnaround time, the disease prevalence that will determine the rollout and the implementation of this test. You have to follow the local recommendations and guidance from your corresponding Ministry of Health. And this is done pretty much through the national labs. And we have compiled key diagnostic training materials from WHO, PAHO, African Society of Laboratory Medicine, and they are available through the websites that Dr. Michael mentioned at the very beginning. So I'm gonna stop there. And if you have any questions, please let us know.
Dr. Correa, thank you very much. We'll invite questions. If you have, please submit in the Q&A and we'll start fielding some of those. One question that has come in is what percentage of recontamination are you facing in your hospital? I don't know if any of the panelists could comment on that. Perhaps Dr. Correa, I don't know if you could comment on that. Again, the question is, what percentage of recontamination are you facing in your hospitals?
But you mean recontamination means like a reinfection of a patient with COVID-19?
I have asked for clarification. If our colleague who's asked that question could expand, please let us know. Otherwise, let's assume that, and perhaps you could answer that question.
Honestly, I don't have that much of the data from our sites, so I don't know if Dr. Chaz has, since you have more.
Yeah, cases of reinfection have been described and seem to be possible more than 3 months after the initial infection. Maybe are more possible in immunocompromised patients who may not produce as effective of an antibody response. But as of now, it's pretty much limited to case reports and suspicion. But in order to really prove reinfection, you need to do metagenomic sequencing to prove that it's actually a different virus that has infected the person.
Okay, thanks for that. Could anybody comment on the global availability of different diagnostics and how that's changed since the beginning of the pandemic until now, and what might be expected in the coming months or longer?
I can start with that. In the low and middle income countries, that is the one that I work the most. So last year when we started with the pandemic, and back in March, it was at the very beginning, we had some rapid tests from Korea, from China, and from Europe, but it was difficult regarding the regulatory part. And also we started to evaluate some of the performance, and many of those tests were not good. I mean, we understand that they are new, but some of the data were not good. We were able to choose one from Korea, the SD biosensor, and luckily in September, when MOH published their interim regarding the use of antigen tests, they had two tests, antigen test in their emergency use list, and they were the SD biosensor, standard Q, and also the PanBio from Abbott. The PanBio is super similar to the Binax that Dr. Chaks mentioned. So that for the RT-PCR, we had a lot of problems with the supply chain and with the training and with the infrastructure. So we were able to establish RT-PCR super late. Just in December in Haiti, but in other countries, they are pretty much, in most of the countries, they are pretty much centralized in the national labs and a few maybe private labs that they offer RT-PCR. So that is like the part that I know from Africa. And I don't know, Dr. Chats, if you want to talk about the Americas.
Yeah, I'm not as familiar in terms of availability on the global front, but even within the United States, which theoretically should have had all the resources available, getting a test was a very challenging thing to do up until maybe a few months ago. It was simply not possible for an average person in the community to find a testing center that would be willing to test them, especially if they were asymptomatic. And in certain cities, this has begun to change as more facilities are able to do PCR assays, and as antigen tests that are accurate have become more widely available. But we should be at a place where anybody who wants a test can get a test. That could really make an impact, I think, in reducing transmission, especially if we think about scenarios where someone might be going to a gathering and may not have had a COVID vaccine, which applies to most people in the world. Being able to know if they're positive or negative could, impact thousands of people depending on how many are at the event. So I think there's still a ways to go.
Thanks for that. The next question, are diagnostic tests available that test simultaneously for SARS-CoV-2 and influenza and perhaps other respiratory viruses? And if so, what is the value or use case for such diagnostics? Dr. Langley, if you want to field that one.
Yeah, so there certainly are tests available that do this. There are some PCR assays that have multiple different targets on them that include all of the common respiratory viruses. I know of at least one antigen assay that tests for coronavirus, SARS coronavirus 2, and influenza. These are not as widely available as would be ideal. And I think as the COVID pandemic comes more under control, it'll be critical to have a test that isn't just focused on a single pathogen, because really we want to understand what's causing someone's respiratory disease. Even before COVID, lower respiratory infections were the leading cause of death in low and middle income countries. And it's a major unmet need in order to figure out what's causing them. Tests are on the way, but they're still somewhat limited.
Thanks for that. Next question, what is the clinical implication and in terms of transmission when a sample has negative antigen PCR positive with a CT of greater than or equal to 40? Sorry if I misstated that question. I'm happy to repeat it.
Yeah, so I think, in thinking about that scenario, there are two possibilities. One, the person could be at the very early stage of their infection. That small window where the PCR test will detect someone who still has too low a viral load to be detectable by a less sensitive antigen assay. Or they could be at the tail end of their infection. They were symptomatic or asymptomatic and positive several weeks before, and they still have incidental shedding virus and are non-infectious. So that would be a scenario where an antibody test would be able to help kind of be a tiebreaker, or retesting the next day. If they're in that window early during their infection, the antigen test should be positive the next day, and the CT value should be lower. So that's how you could figure it out.
Thanks for that. Next question, where is antigen testing being used to its true full potential to identify highly infectious individuals and implement community control measures? Schools, workplaces, other settings, and if not, why not? Dr. Correa, would you like to comment on that?
Yeah. There are, I mean, I went through through those scenarios really fast, but they are in the WHO website, and also in the Americans, I mean, in the Africa CDC interim, where they have all these scenarios for use of the antigen test. So as Dr. Chaz presented, they are useful. They are still useful because they are good for detection of highly infectious people. So you can, and in fact, we have some algorithms that we can also share. And so some of those algorithms can help the stakeholders to look for the implementation. But yes, I mean, the antigen test, you can use it for detection of the highly infectious patient.
You know, in San Francisco, we're starting to see some community screening initiatives, including at the subway stations, at community centers, to try and identify people who are infectious, who may not realize it, so that they can prevent transmission. But that hasn't really, that type of, free community surveillance is certainly heterogeneous in terms of availability.
Yeah, and I think, for example, in some of the hospitals, if they are in a remote areas, you can test, for example, the healthcare workers. You can test it like every week or every 2 weeks, or you can test in the TB wards. You can test those, those like are examples where you can use the antigen test as well for screening.
Thanks for the comments. We're up at the end of the hour. And for those who are able to stay on, we're happy to stay on and answer any final questions. I will also be staying on for those who would like an introduction and orientation to any of the resources that were mentioned in the talks that are on the COVID protocols portal and the Open Critical Care portal that are specific to diagnostics, both training and reference material. So please stay on and I will walk through that. Also, you'll notice a poll. I'm just trying to gather a little bit of information, as well as in the link, in the chat, there will be a link so that you can sign up to receive updates and invitations to future webinars. So we want to thank USAID for the support and STAR for our collaboration, for everyone's time for joining, our panelists, Dr. Correa, Dr. Langlier, and Ms. Ben for taking the time to be here with us. We'll stick around for a few more minutes. And everybody, thank you very much for your time and participation. And for those who are staying on, there's one question for Miss Ben. If you don't mind, just if you wouldn't mind commenting on the experience at Navajo Nation and how perhaps, with challenges that you faced in terms of getting access to different diagnostics and supplies to keep the lab operational, and also how you anticipated that. Any comment would be, I think would be of interest.
Oh, yes. For us, we were very fortunate that we had a very intelligent microbiology supervisor. And I guess when COVID first became a national headline, she did take the initiative to start looking into it, and she was able to acquire a lot of the collection materials that she thought we might need at the beginning. So she went ahead and she contacted some of our normal lab vendors and ordered a lot of NP swabs, which is the main collection that we use, is the nasopharyngeal swabs. And then she also ordered a lot of the VTMs and stuff. So when it hit our area, we were pretty well prepared. We didn't have, at the beginning, we did not have any testing methods, and we were sending everything out to our reference laboratory, LabCorp. And then we were able to bring on, we already had a gene expert in our laboratory, but we just didn't have the test cartridges. And Cepheid would tell us that they're coming out with something. And it wasn't probably until late April, early May that they finally came out with a single SARS cartridge. And that's what we used. And it was good because our facility also established a tier protocol to how we were going to screen and test our patients. But then at the same time, we also were able to get some ID Now analyzers. And that's the main system that we use for our testing. And it worked out pretty well. I did want to mention though that as far as somebody asked about if there's a platform that you can do that can identify other respiratory agents other than just SARS. Cepheid does have a new cartridge that's a 4-plex, and you can actually detect SARS, flu A and B, and RSV on a single cartridge. And then also there's the BioFire analyzer that has 13 targets on their panel. It's a very costly test, but you can detect organisms such as SARS, flu, RSV, mycoplasma. I'm trying to think some other ones, but it has 13 targets on that one. And we, like I said, here at our facility, we do have a mechanism and a protocol in place on how we test our patients. But one thing we did to really try to keep on top of our inventory and everything is we had a daily inventory process that we had to do, which we took note of how many tests we did on which platform, and we continue that to even to today. And then we also monitor how many supplies we have on hand so that we don't run out of stuff. I don't know if I answered the question, but.
That was great. Thanks so much, Ms. Ben.
Okay.
So at this point, I'm going to go through just a quick walkthrough through some of the resources online, and want to thank everybody again for taking the time. Ms. Ben, Dr. Langlier, Dr. Correa, thank you so much for joining us today. And for those who want to remain on the line, please do so. I'll just briefly walk through some of the resources as a quick demo. Just be sharing my screen here in a minute. So you should now see the Open Critical Care portal. So for those of you who haven't been here, welcome to the Open Critical Care portal. This is a site that we have created with support from USAID in partnership with STAR and many other collaborators to try and create a repository of critical care training material, initially with an emphasis on respiratory care and COVID, although the scope of that has become significantly broader, and we're trying to use this site to house materials that can be useful specifically during the pandemic. As relates to the talk today on COVID diagnostics, I want to highlight just a couple of features on the site. One is right off the main page, there's this sign up form here. Here you can enter your email address and receive updates and emails. This will also be a place where you can get invitations to the webinars. This link on the homepage, view our suggested training resources. I'll go ahead and click here. And on this page is a menu of trainings that we are curating from around the web. And for COVID diagnostics, you can click on this panel here. What you'll see are, again, mostly training materials. These are intended to be self-directed in most cases, and they're organized by both language or by level of learner. You can select those filters and then scroll through to see some of the training material that was highlighted today. such as the training courses by the African Society of Laboratory Medicine, some of the diagnostic training material, diagnostic testing material created by Partners in Health. And then towards the end are supplementary resources. And here you'll notice a link which will take you to our COVID-19 resource page on the website. Here are featured content, but also a list of all resources. And if you filter by diagnostics, it will show you all resources relevant to diagnostics that we have on the portal. Again, training material from ASLM and other leading authorities, as well as reference material, algorithms, articles that have been published, information on the latest diagnostics, where to find them, what their sensitivities are, etc. And then finally, the last thing that I'll highlight, which is linked off the homepage, is the covidprotocols.org website, which was created in partnership with Brigham and Women's Hospital and Partners in Health with support from USAID. On this site, in the left-hand menu is a COVID testing section. On this testing, it covers much of the material that we talked about today, and also can be available in Spanish by switching to the ES at the top left of the screen. Most of this site is now available in Spanish, and all of the site will be ready next week in Spanish. So I'll go ahead and stop sharing my screen there. Want to thank everybody again for joining. If you have any additional questions, please be in touch with us directly. Thanks very much.
Thank you very much.
Take care.